talking about type 1. This presentation was in a dilemma whether type 1 or type 2. But mine is confirmed type 1. So, but still there are challenges, and overcome challenges we'll try to see. Type 1, as we all know, it's the disease where there is absolute efficiency, and it accounts for around 5 to 10% of the diabetes worldwide. I'll say little uncommon, but not so uncommon, and it's picking up, and globally also it is picking up, and in India I think it is around 3 lakh type 1 patients. 9 lakhs. Not that uncommon. And from the first presentation, we learned that in the young age group, type 1 is accounting for around 40% of the cases. But early type 2 also accounts for around 40%. There are different types of diabetes which can be found in the young adults, but I'll be concentrating only on the type 1 patients. And you can see the onset is very fast and aggressive in the children's, but in adults it can be latent. Initially we think it to be type 2 diabetes or something. Initially we treat with oral medications, and when they fail and we do the antibodies and get positive, then we call it SADA. And that's again the kind of type 1 diabetes. In type 1, there are different stages. Why I'm putting the stages? Because you can screen for type 1 patients if they have family history. And the stage 1, stage 2, and stage 3. Stage 3 is where it's a confirmed diagnosis. They are symptomatic, and antibodies will be positive, at least 2 antibodies if it is positive. That is a stage 3, which we get. But in the earlier stages also, there will be immunity, autoimmunity, which will be positive. And various genetic, mutations will be seen. Those will be positive in the earlier stages also. And in stage 2, they will be pre-symptomatic, or dysglycemia will start to happen along with the autoantibodies, but they are not overtly going to the diagnosis of diabetes till they are in this stage 2. But in stage 3, they are frank symptomatic with autoimmunity positive. So with that, we can know that if there is a family history of type 1 diabetes, maybe we can screen the other siblings for the autoantibodies also, and then we can get them prepared for treatment later on. At diagnosis, typically what we see is the HbA1c and the fasting and PP for diagnosis, but in type 1, again, since it is very acute onset, you may not get HbA1c above 6.5 always. If you get frank hyperglycemic symptoms, typical of type 1, more than 250 sugars, or ketones positive, and you check the antibodies, if it is positive, then definitely we'll rely it to be type 1 diabetes, in spite HbA1c being little less. Not mandatory that HbA1c has to be above 6.5 to label them as type 1. So targets will be a little different for different people, but ideally we try to keep the preprandial sugars around 80 to 130, and postprandial we target around less than 180. But HbA1c targets again differ depending on the different age group. We'll try to see what obstacles we can have or difficulties we can have in managing the type 1 patients. So HbA1c, I'll not say in all the patients it is not possible to keep the A1c less than 6.5 or less than 7. We may get in the young age group even 8% A1c is still a good A1c to be expected to be a good control. So in management, we have to rely on first the fundamentals of the nutrition, or simple carb counting. We have to counsel the patient to have an idea how much insulin will be required for how much carb. At least that simple things we have to teach the patient, and importance of physical activity. Apart from that, sometimes I'll say most of the patients will require some psychological counseling too. And we know that type 1 management will be insulin, purely insulin, and that too, current guidelines say that it should be multiple dose injections or basal bolus therapy, not the premix insulins. And monitoring has to be there, structured monitoring and frequent monitoring of sugar, and to titrate the doses to keep the sugars well controlled. We have to prepare the patients for hyperglycemia management as well as the hypoglycemia management. Definitely, both the things will be expected when you treat a type 1 patient with insulin. DSME is one of the major points where they have to be taught about diabetes self-management. If we give a prescription and think that they will be able to just follow the prescription and keep the sugars controlled, it's not going to happen. We have to give them a structured way how to do their daily things while managing their sugars. Let me come to the challenges, what we can expect. In children's mostly, these are the challenging things. Lifestyle issues, variable routines may be there, exams, holidays, sports, etc. They avoid sugar testing. Frequent monitoring of sugar is little difficult, and frequent pricks the children may not allow. In adults, it is little more possible to tell them to do and expect them to do frequent monitoring, but for children it's difficult. Daily injecting and monitoring in school also it's difficult. Non-physiological insulin preparations are used sometimes, like premix insulins, as I mentioned. It may not be very suitable for a type 1 diabetes management. And in fact, if we are using basal bolus therapy also, for snacking also you have to give bolus insulins. Majority of the times, 3 boluses, 3 major meals, and basal insulin is given 4 times. But sugars are not well controlled. Evening time they snack, and pre-dinner sugar is always 300, 350 like that. They are not going to ketoacidosis because they are taking the 4 doses regularly, so not going to ketoacidosis, but sugars are not well controlled. So snacking also requires bolus dose, and cost of therapy sometimes gets difficult for type 1 families who are from the resource restrained or not very affluent. They feel difficult to control, procure insulin and the glucometer strips, because frequent monitoring again will be requiring money to procure the strips. Those are little challenges, but that's an overview of the challenges what we can see. But these challenges again can be different with different age groups. Type 1 you can get commonly, age group is 5 to 7 years, or say pre-puberty you get the common age group children's, but you can get different age groups. I have one patient, his age is 4 years. Another type 1 patient, her age is 55 years. She had been type 1 for last 30 years. So different age group patients will be there, and they will have different management difficulties while managing their sugars daily. I'll go into little details about the different age groups. In the infant and the toddler age group, what obstacles you can see or in the management from the patient perspective is that they have limited cognitive capacity, poor communication skills, lack of cooperation, and autonomous behavior is there. So these are the very difficult patients to treat with insulin and to keep the sugars well controlled. As a caregivers, parents and all, they will not be able to recognize hypoglycemia, because the toddlers, they will not be able to tell that they have they're feeling low sugar or something, or palpitations. They will not appreciate, they will not understand that, and they do not follow a healthy eating habit. Whatever is fed by the parents, or they hear from the neighbors or family members, they will feed accordingly, not what a type 1 patient fed. So psychological distress and burnt out may be there as a caregiver. In this age group, mother will be injecting the insulin, and again, say feeding and all, everything, household chores will be there. So it's difficult for managing the sugars very effectively. and that may adversely affect the family as a whole. So how to have a solution to it? We should give a structured education, P1D education to the family, the parents. Here, the patient is not the receiver of the thing. And we have to integrate user-friendly technology solutions. We have to look into what kind of family background they are and how much, they are savvy about the newer, technologies, and then we have to guide them accordingly. And again, counseling services will definitely be required in this group of patients and the family. If we move up to the next age group of preschool and early elementary children, we can see that limited language and cognitive function, ability to express symptoms are little difficult, and developmental behaviors tend to exhibit, and those sort of difficulties may be faced. And for the caregiver also, there are a lot of concerns about managing the diabetes in these settings. So we have to again implement behavioral interventions to address the indicators. Here we'll be dealing with the patient because they are little now able to understand something, and we have to develop individualized diabetes management plans at the school also. We have started one NGO with a patient's mother, and we are trying to do school education programs to talk with the teachers, talk with the school children's. If someone is diabetic, we'll talk to them, and if someone is not diabetic also, we are talking to them. Create some awareness. If any, classmate is diabetic, what to observe. And then those sort of things can be done. A few pictures of where we do the programs, and we do that regularly. As the age group goes higher, the solution, the problems also become increasingly more complex. And again, we have to have solutions to it. I'll not go in details, to all the solutions. These are the practical points which will eventually manage the sugars effectively. Treatment is, we all know, insulin, and only insulin with little adjunct therapies which Madam has quoted, but not a substitute. Insulin is the only treatment. There are advances also which gives little edge in treating diabetes, type 1 diabetes effectively. CGMs have come. There are different types of CGM we are using, and acceptance is increasing, and it's improving the diabetes care immensely, but we have to use the technology properly. Advances in treatment is also there. Insulin delivery devices have come, insulin pumps, closed loop pumps. I think she is using a closed loop pump, 780G. Yeah. So two of my patients are using 780G pumps, but most of the patients are not able to afford the insulin also. And that's why we started this NGO, and we are getting funds, and we are giving free insulin, free supplies of insulin and the strips on a regular basis. Help those kind of families. Some of them can afford, they are using pumps also. So these are little advances which will improve the type 1 care, but still the treatment is insulin. And Madam had already mentioned about the immunotherapy, which is an emerging thing, has recently happened, and maybe in near future, if cost comes down, which I don't think it will come down very soon, may have some cure or for type 1 diabetes. So different types of pumps are there. What is commonly available in India is the Medtronic pumps, which we are using, but there are different pumps which are expected to come. Roche is, I think, coming in India with an insulin pump, and the recent pumps are quite effective in controlling the sugar because it is almost working as an artificial pancreas. So, to summarize, type 1 diabetes commonly presence in the childhood or adolescence, and symptoms we all know: polydipsia, polyuria, polyphagia, weight loss, and fatigue will be there, and they will be requiring, say, insulin lifelong, and mostly the basal bolus therapy. And if someone is able to use an insulin pump, it is definitely having some benefit from the basal bolus therapy. But even if someone is using a pump, we have to keep the pens ready. Sometimes the pump may not work properly, or the catheter may kink, or issues may be there. So suggest that they keep a bolus insulin, at least the pen should be there available in case of sugars going high, and we can use that in a timely manner, prevent ketoacidosis. Apart from insulin, some adjunct therapies are also there, which is there, and maybe users will improve in the time to come. And technology definitely plays an important role in managing the type 1 diabetes, and just that the affordability part and the user friendliness of the technology has to be there to make it being used by a lot of type 1 patients. So thank you so much for the patient hearing, and over to Chairperson.